Hello, and welcome to another episode of the JBI Evidence Implementation video commentary series. I'm Jonathan Bayuo, a clinical academic nurse from Ghana, West Africa, specializing in burns, plastics, and reconstructive surgical nursing, actively involved in clinical practice, research, and education. A note of appreciation to the JBI and its network of collaborators for the opportunity to develop a commentary on the article titled Implementation of a Coronavirus Disease 2019 Infection Prevention and Control Training Program in a Low-Middle Income Country, authored by Narangela Pereira and her collaborators in Sri Lanka and Toronto, Canada. The coronavirus disease 2019, abbreviated as COVID-19, is still evolving across the globe and poses a great threat to healthcare providers. This is particularly true for low and middle income countries, or LMICs, where resource constraints, waves of the infection, and limited access to vaccines have disproportionately burdened existing healthcare systems. To safeguard the well-being of healthcare providers, it is critical to provide contextually relevant infection prevention and control, or IPC, guidelines and training as needed. Existing IPC guidelines, however, have either emerged from well-resourced settings or are too generic to be readily applied within the context of LMICs, which create a gap regarding how well to support healthcare providers who find themselves in low-middle income countries. Besides, there's little literature available on IPC programs during the COVID-19 pandemic in LMICs. To this end, the authors who had previously developed a COVID-19 IPC training program sought to implement the evidence-based role-specific training program for healthcare providers in Sri Lanka. Firstly, an interdisciplinary team developed the IPC guidelines for healthcare providers working in inpatient, outpatient, and primary care settings. The role-specific guideline documents offered a comprehensive and contextually relevant overview of IPC consideration for COVID-19. These were paired with desk guides for quick reference by the healthcare providers if required. The COVID-19 IPC guidelines covered a range of topics, including an introduction to the COVID-19 pandemic, COVID-19 diagnosis and management, advice for mental health, tips for COVID-19 prevention, including an overview of the use of personal protective equipment, or PPE, and donning and doffing practices. The content of these were translated into PowerPoint slide presentations for field health staff and hospital staff. PowerPoint presentations for field health staff and support staff were translated to the local language at the study site in Sri Lanka. From these PowerPoint slides, training videos were developed as additional teaching tools to enhance the IPC training program. The topics and content of these videos were in line with the training materials. However, certain skills were selected to emphasize key areas for learning, which included hand hygiene technique, donning, doffing technique, obtaining PCR samples, and carrying out rapid antigen testing in field health settings. To implement the training program, 6 training sessions were held. Each session lasted 1 hour and was led by a training leader. A pre-test was completed by participants prior to each training session, and a post-test was also completed at the end of a training session. Following the implementation of the training program, the authors observed that the mean score regarding IPC knowledge improved from 77.14% on the pre-test to 84.06% on the post-test. On further analysis by professional designation, the authors observed a significant increase in knowledge across all the professional groups, which included physicians, nurses, public health midwives, and supportive staff. Put together, the results suggest that the training was helpful in improving COVID-19 IPC knowledge strategies among healthcare providers. Additionally, the results emphasize that during complex emergencies, such as the COVID-19 pandemic, IPC training must be extended to all staff as the conceptualization of who is on front line and at risk for infection expands. Notable factors that contributed to the success of the program include having senior staff members as program champions, which help to identify and address implementation challenges. And secondly, the use of multimedia platforms to communicate the guidelines to participants. Despite these, some challenges are noteworthy. First, time for the different staff categories in different shifts amidst the heavy workloads was a major challenge. Secondly, during the time of implementing the training, hospital staff were overwhelmed by repeated staff quarantine because of COVID-19 exposure and having to cover staff duties at a temporary COVID-19 intermediate treatment center. There were also challenges related to conducting the training assessment. This included a limited evidence base on IPC assessment surveys in the Sri Lankan setting, uncertainties as to the appropriateness of the assessment modality for some staffing categories, and challenges with ensuring that staff were able to attend both the pre-test and post-test, given their other responsibilities. As a concluding remark, it's worth mentioning that implementing the IPC training program during a health emergency such as the COVID-19 pandemic is a necessary task, albeit challenging. It is possible to leverage champions and consider other innovative strategies of disseminating the training programs, such as the use of multimedia platforms. The full text version of this article is available in the JBI Evidence Implementation Journal, and wish to reiterate my note of appreciation to the JBI for this opportunity to develop this commentary. Thank you.